the orthoPAC, hosted by Sam Dyer. Welcome to the orthoPAC, where we discuss up-to-date orthopedic topics for the busy clinician. I invite you to sit back and relax as I attempt to fill in the gaps between education, current events, and real-world practice. Today's podcast, you got Chuck Dowell, Miles Gilbreth, and myself discussing how do you manage things if you're not sure. I want to throw in something that makes our surgeons kind of bristle. You see something in an urgent care and you have them follow up in 2 to 3 days to rule out a fracture with the surgeon filling up their schedule. That is just not a right thing to do.
Correct.
If you see, have you had anybody kind of get blistered from that, Chuck? It's been an issue in our practice, especially with new folks, because they feel like they've got a safety net. They're so busy, and how am I going to reach somebody? I'm afraid to call somebody. I'll just have them follow up with this doctor and see.
Well, are you alluding to like not much is going to change in that couple days? Is that what you're?
Exactly.
Yeah,
Exactly. Yeah. That's
yeah,
and the patient's got to make 2 copays, and the doc's
correct,
looking for surgeries, and they got this little simple fracture, and yeah,
correct.
and they're not real happy with that. The reason why I bring that up at all is I was teaching a fracture reduction clinic at the Ortho Boot Camp a week or two ago, and people were asking about follow up. If you have something that you think is positive, and you're going to know it, I mean, you're seeing enough patients, you're a provider, you know what's going on. If something has, like the kid that won't walk, is it transient synovitis? Is it a fracture? Or, a Salter 1, like Miles had talked about earlier. You're going to see that kind of stuff, and you don't know. The best thing to do, the best way to manage it, you have them rest it, you have them ice it, you have them wait, and you take the films and you show them to somebody you trust to look at the films or the images and tell you what it is, what you think it is. You present the history, and then you call the patient and say, hey, you got this. I didn't see it. Dr. So-and-so saw it. This is what we need to do. Come back. Let's fix it. Don't have that person come back in 2 or 3 days and you just forget about it. It's more, you've taken this patient on, you're seeing them, you need to follow it through. So make sure you do that. And it's just an important thing. It's just bad business to say, come back in 2 or 3 days and let the doc, determine, because the patient's paying more money, and it's just not good to do it that way. It's better for you to communicate kind of outside. And that's my opinion. I think that's a better way to manage. And you can take that to any other diagnosis that you've done. If you're not sure 100%, once you're finished with your busy day, go talk to somebody. And if it's a really acute thing, obviously you got to call the on-call doc, right, and work it up. And you get behind. It happens. And you just do the best you can.
That's a really, really good point. Our docs often, get frustrated by that, by, maybe a younger PA in practice or some of the younger PAs that we're mentoring in the orthopedic urgent care. They see something, they say, hey, I'm not really sure. You see your pain seems to be out of proportion of what the x-rays are showing. I'm just going to have an early follow-up, have you see the doc in a couple days, and they'll kind of re-examine you. And that's difficult for the doctor because it puts them in a tough position, because there not much will change within that first 3 to 5 days. They're still going to be painful. They're still going to have limited range of motion. Likely their x-rays won't change. And so they're just going to reaffirm your evaluation, and say, hey, yes, I completely agree with them. And then the patients are frustrated because they potentially didn't get much from that. So yes, correct. If they're gonna follow up, I think more of that 7 to 10 day window is a better follow-up time, because they'll be outside of that acute inflammatory phase. Maybe then they'll get those changes on the x-rays that could show up for those occult fractures. You can redeclare those, physeal Salter 1 fractures. As Miles alluded to, if some of those cases is follow us home at night, we say, hey, that just didn't fit, everything just didn't fit the clinical picture. That 5-year-old that wouldn't walk despite the negative x-rays, it just doesn't make sense. Go review those x-rays again the next day. Go talk to one of your colleagues the next day and re-review that case. I can't say 100% of the time, but the majority of the time, the family is going to be very happy that you called them and said, hey, I re-reviewed your case. I was thinking about your case, and I'm concerned that maybe something more significant is going on here. I've never had a family be upset that I'm calling them the next day and saying, hey, let's maybe take the weight off of it. Let's maybe go get some crutches. So I agree with you 100% on that, Sam.
I completely agree with appropriate follow-up timing. So I joined my practice right at the onset of our urgent care clinic, and there wasn't really many other models in it. There were no other urgent cares in Atlanta that we had to model from, and my physicians weren't familiar with the concept particularly, other than they knew they wanted it. And when I joined, the initial rule that I was presented that every fracture we saw needed to follow up immediately with a specialty team. I mean, they wanted to happen the next day. And from the onset, I kind of advocated for, hey, when appropriate, surgical patients, yeah, I'm gonna get them on your schedule ASAP. But for these non-displaced conservative treatment fractures, it needs to at least be a week, right? And I advocated it for it very early and didn't get much pushback from the physicians. So yeah, I think I had the opposite experience of my group wanted them to follow up quicker, and I had to kind of say,
Mhm.
hey, maybe not, guys. Like it's just going to burden your schedule, and they got the picture within several months, essentially.
Typical surgeons, in my experience, are doing, seeing 50, 60 patients, whatever, in clinic because they're farming for surgeries. And if you're
Mhm.
sending a little ankle sprain, buccal fracture, whatever, back in 2 or 3 days, that fills up their spots where they could potentially get another case, they're not thrilled. That's my experience. But whatever they want, I think the newer facility like that was probably because they didn't want anybody to miss anything. They're worried about liability. I don't know how that is, but I know in my situation, yeah, if I put something like that on, I better have a good reason for putting it on and taking up that precious spot where they might find a case.
Yeah, it only takes a few of those office visits for those surgeons to see where you're following up with somebody 3 days in and there's not much they can do or change. The x-rays are still negative and the patient, their family members are frustrated. They'll say, hey, I agree with that more prolonged follow-up to unload and unburden the clinic. And even if, let's say, it's something that's subtle that's missed, that 7 to 10 day follow up is still within a time frame where it can be correctable and fixed. And so I think that's an appropriate time frame to have a lot of these patients follow up. And you, Miles, being in an urgent orthopedic urgent care as well, see that all the time where you get patients from urgent cares or emergency rooms that follow up with you in a couple days. And you're like, well, there's not much I can change at this point. Everything's been done appropriately. Let's have you follow up again and reassess at that 1 week period.
I do want to go over one other point, and we had talked about this some, and you guys had mentioned it. Whatever you do, no matter what somebody else did, do not say in front of a patient, "Oh my God, I can't believe they did this," or "Oh my gosh, what in the world were they thinking?" Those are the triggers that generate malpractice lawsuits, and it happens. Say whatever, but don't criticize somebody else. That's just one of the worst things you can do. And that I did a podcast with some defense attorneys early on, and they said that was the biggest reason why lawsuits happen, because somebody else criticized somebody else's care. Just don't do it. It's bad business for everybody. Avoid that. Now, in private, if you say, "Can you believe this x-ray?" or "Can you believe that they did this?" or whatever, that's one thing where you're discussing things among colleagues, but never do that in front of patients. It's just really bad business. And I want everybody listening to this to take that home, because it happens all the time. And that's why lawsuits happen. So stay away from that. The other thing is, you're worried about mistakes. And Chuck, your colleague, I get it. Oh my God, what am I doing? Am I going to get sued? Somebody going to lose their leg, et cetera, et cetera. Be honest. Tell the patient what you're thinking. Make sure to call. If you treat something and then forget about it for a week and something happens, then you're in trouble. But if you treat something and something's just not right, or you get the call back, follow up on it. Make a call, have your MA call, get more details. Anything else, bring them back into the clinic. Say, "Well, I don't know. Why don't you come back in? Let me take another look at it." When you do things like that, you're well within standard of care. And even if you don't know 100%, if you can't figure it out, then you can get them to the right person. And that's the way to handle that kind of stuff. It's not like hope for the best and forget about it. That's a bad way to go. So, my 2 cents.
Yeah, I agree 100% with everything you said. Yep.
Yeah, same. It's karmically not the best to put down other providers' care, and so I'm very careful with that.
Wait a minute. You're bringing karma in an orthopedic discussion?
I am, yeah, yeah. Karma and dharma, it permeates everything, right?
Oh, all right. Well, I believe in karma, so maybe it's there. I also carry a pair of dice in my pocket for good luck. So there you go.
There you go.
Uh,
I used to have in PA school. I had um, this delves into it. I had a perfectly symmetrical black and white rock that I had found through the years, and you like The Alchemist, if you've ever read it, and I would pull them out sometimes for a decision, and I ended up giving them to one of my classmates who saw me doing it and thought it was one of the funniest things she'd ever seen. So I don't have my black and white rock anymore.
oh no. Well, good luck
okay.
charms come and go, I guess.
All right. Yeah. Good deed. Karma.
Yep. So Chuck Dowell, Miles Gilbreth, and me, Sam Dyer. Panel discussion. If you guys like this or have some topics you'd like us to discuss in the future, let us know. Chuck has his own podcast called Ortho on the Go, and it's a clinical-based discussion on orthopedics. He has a lot of relevant information. I hope you'll go to listen to that. Again, it's Ortho on the Go with Chuck Dowell.